Good afternoon. My name is Tiffany, and I will be your conference operator today. At this time, I would like to welcome everyone to the National LAN event. All lines have been placed on mute to prevent any background noise. After the speaker's remarks, there will be a question and answer session. If you would like to ask a question during this time, simply press star, then the number 1 on your telephone keypad. If you would like to withdraw your question, press the pound key. Thank you. Lindsay Cates, you may begin your conference.
Thank you so much. Good afternoon, and thank you everyone for joining us for the National Learning and Action Network, or LAN event. We are very happy to have you with us today as we discuss the important topic of engaging physicians and care teams to prevent and manage diabetes. My name is Lindsay Cates. I'm a program specialist with Television and the Quality Innovation Network National Coordinating Center, or the QuinnNCC. So we have a few reminders and housekeeping items before we get started today. Thank you for joining us in the WebEx Event Center. You will need to access your registration confirmation email and unique registration ID to log into WebEx. We have a slight change from this picture here. It's actually Susan Brittman from QSource and the QuinnNCC who will be monitoring our WebEx chat board. So be sure to look for her name and participate as we go along, and feel free to ask your questions. Slides, resources, and the recording from today's session will be posted on qioprogram.org under the News and Events tab. And you may see some of the resources already posted there if you have been to that website. And Susan will put that in the chat as well for you. So we'll start by reviewing today's agenda. First, I will go over the continuing education, or CE details. Then I will introduce each of our speakers today. We have Sue Flex with the Centers for Medicare and Medicaid Services, Dr. Kate Curley and Kenneth Henderson from the American Medical Association, and Joan Bardsley from MedStar Health Research Institute. We will have multiple facilitated discussion portions during which we will address questions posed in the chat and via the phone lines. Please note we do not get to your question right away. We are compiling them and will attempt to address as many as possible during the facilitated discussion portion. And finally, I will wrap up with a reminder to complete our post-event assessment and a plug for some upcoming calls. Okay, so I'd like to take a moment to remind our participants about the purpose of this important series of learning and sharing events. Without reading all the content on the slide, I'll mention a few high points. The audience is very broad and includes a variety of healthcare provider types, partners, and patients. The purpose is to offer virtual learning and sharing events with a focus on ideas and concepts related to healthcare quality improvement. We would like to ask that you all think of actionable ways to implement the ideas and concepts presented today and make a commitment to share the information with your own teams. And finally, we are always open to new ideas and suggestions for topics to bring to this audience, so please feel free to send your ideas through the chat and or through the post-event assessment. And now to address the direct purpose of today's event, we will prepare healthcare quality improvement professionals to identify and implement effective healthcare strategies by exploring promising practices to engage physicians and care teams and prevent and manage diabetes. So we are hoping to make this as interactive as possible, which can be challenging given such a large audience. So we ask you to commit as individuals to be attentive, active, and actionable, thinking about all the ways the content is relevant to your work and priorities. We welcome your active participation by clicking the green check in the WebEx application. You can click the conversation bubble, choose yes in the drop-down menu, or you can also just tap yes in the chat box so that we know that you are committing to that for today's call. And we are very excited to be able to offer continuing education credits to all attendees for participating in today's session. We offer credit to all physicians, physician assistants, registered nurses, nurse practitioners, dietitians, pharmacists, and pharmacy technicians. We also offer certificates of attendance, so should you have requests for additional accreditation types, we welcome those suggestions as well, and you can put those through the chat or the post-event assessment. Thank you for all of your yeses in the chat box as well. So in order to apply for continuing education credit, you must have attended the entire event. You must complete the post-event assessment upon exiting the WebEx session, and that will pop up as soon as WebEx ends if you do stay on to the end. Note that the CE evaluation can only be accessed by following the application site hyperlink at the end of the post-event assessment. And if you have any technical assistance related to the CE, if you need technical assistance related to the CE process, please email Nikki Rosales. Susan is going to post her email address in the chat box. I have to go through some disclaimers. So this is one from our partnering provider, CRW Associates. This activity awards 1.5 AMA credit hours for physicians and physician assistants. You may reference the slide for the full CE statement. And this activity also awards 1.5 contract hours for nurses and 1.5 continuing professional education units for dietitians. To follow are the accreditation statements for those entities. And another disclaimer, we would like to report that the planners and faculty for this event, CRW and Associates and Television, do not have any financial relationship to disclose, nor was any financial support received for this activity. And finally, we have disclosures of financial relationships for your records. Again, you must participate in the entire live activity to claim continuing education credit. Okay, so we can move on now. We want to get an idea of what types of organizations are represented on this call. So we're going to invite you to respond to a poll indicating where you are working. So Nikki, if you could open the poll. You should see that in the right sidebar of your WebEx screen. And while we are waiting for the poll results to load, I'm going to review our session objectives. By the end of today's call, you should be able to articulate the American Medical Association's or AMA strategy to prevent type 2 diabetes by working directly with physicians and care teams to identify patients with prediabetes and referring patients to a diabetes prevention program. To be able to identify the services and resources available through the AMA to implement the screening, testing, and referral process in healthcare organizations. Highlight key considerations relevant to upcoming coverage through Medicare for eligible beneficiaries who participate in a diabetes prevention program. Describe the 4 critical times to assess, provide, adjust, and refer for self-management, education, and support. And finally, list 3 tools available to support the dissemination of the recommendations stated in the joint position statement. All right, so the poll results we have today. Looks like we have some hospital representation, a lot of QIOs, and some others. So if you wanted to chat in your other, please go ahead and do that. Looks like we have a grid with no answers as well. Oh, great. Thank you for putting in Philwatt Health Department, YMCA, F2HC. That's great. Thank you. So now I'm going to introduce our first speaker. Sue Fleck is the subject matter expert and lead for the Everyone with Diabetes Counts Initiative, or EDC, with the Centers for Medicare and Medicaid Services, or CMS. Sue will provide a national perspective on diabetes prevention and management efforts. Thank you for being here, Sue. The floor is yours.
Hey, thank you, Lindsay, and thank you, everyone. I'm thrilled to be speaking with you today about EDC, or Everyone with Diabetes Counts. This is going to be a very quick, high-level overview in the interest of time. There's a lot of information in these slides, and as Lindsay mentioned, you'll have access to the slides so you can review them in more detail later if you would like more information about EDC. I did want to just include the CMS equity plan for Medicare. There are 6 priorities. That's the slide that I'm looking at now. So CMS is looking at standardizing data, integrating equity solutions across CMS programs, developing promising approaches, increasing the ability of the healthcare workforce to meet the needs of vulnerable populations, improving communication with and language for individuals with limited English proficiency, and increasing physical accessibility of healthcare facilities. So those are the priorities we're working on now. I did want you to see these. This is the diabetes prevalence. These are Medicare expenditures attributed to diabetes. Most of you are in this field, so you know that the incidence of diabetes and the prevalence will increase as people age. So in the Medicare population, which is what we target in EDC, 60% of Medicare beneficiaries have multiple chronic conditions. And if you look at the second bullet here, 15% of Medicare beneficiaries have 6 or more chronic conditions, diabetes being in the top 6. But these account for 51% of Medicare spending. And of those people who are duly eligible or Medicare, Medicaid beneficiaries, they also have 6 or more chronic conditions. This information is in the CMS chronic conditions among Medicare beneficiaries chart book. Medicare CMS issues a chart book every few years. We try to update it. So So I did want to also, this last bullet has been, since 2013, this was a testimony by the American Diabetes Association in front of Congress. So 26.9% of Medicare beneficiaries age 65 or older have diabetes, but if you look at the rest of this, that accounts for 32% of Medicare spending. So definitely we're looking at how we can control some of this. Diabetes statistics, and this is from the CDC. Their CDC's National Diabetes Statistic Report of 2017. I've given you the link here, but just some of the highlights I've listed just to go along with what we're seeing also in Medicare. These statistics are not specific to Medicare. These are all adults, but it's interesting though still the 65 years or older population comes up very high. Type 2 diabetes accounting for 90 to 95% of all diabetes cases. And then there's a breakdown of racial ethnic groups, and the highest being American Indian and Alaska Natives. So I wanted you to see that. And also, we did not want to forget the rural population, the last bullet on this slide, from the Rural Health Research and Policy Centers. And people who live in rural counties have a 16.7% higher incidence of diabetes than those who live in urban areas. So frequently we leave the rural component out, but I wanted to focus on that a little bit. Okay. So everyone with diabetes counts, or EDC, this is our 10th anniversary this year. EDC started 10 years ago as a one-state pilot in Florida, then expanded to 9 different states and U.S. territories, and we were fortunate enough to receive funding to expand it nationally as of August 1st, 2014. The QIO contract is a 5-year contract, so the expansion is from August of 2014 through July 31st, 2019. And this is the largest national Medicare diabetes self-management education program that focuses on beneficiaries in underserved, minority, diverse, and rural populations. The goals of EDC. So we want to improve health equity and improve health literacy. This is a disparities reduction program, as I mentioned, so certain populations are targeted. Most importantly, we want to engage not just beneficiaries but healthcare providers, and that is to decrease the disparity in diabetes testing and improve testing and measures for hemoglobin A1C, lipids, eye exam, foot exam, blood pressure control, and weight control. And the overall goals here in EDC also include a sustainability plan and sustainability work that we want to engage public and private agencies, organizations, community, state, and national level to develop their own sustainable diabetes education programs. The QIO funding is limited, so we want these communities to be left with some sustainable education resources when the QIO contract ends. I would be remiss if I didn't mention health literacy and just general literacy. In all of these populations we've run across as QIOs will tell you that there's literacy issues, illiteracy issues in many states. So these statistics are from the U.S. Department of Education. December 2015 were the most recent that I could find. But sad to say that the Department of Education has said that the current literacy rate in the United States has not changed in 10 years. And if you see these percentages, high percentages of people are still reading at a very basic level, which is a 4th grade level. Demographically, these adults read below the 4th grade level, 41% of the Hispanic population and 24% of the African American population. So this presents a challenge in all diabetes education programs, and specifically in EDC, I will go over a little bit later how we approach some of that. EDC has 5 components. As I mentioned, it is not just beneficiaries and recruiting and enrolling them in self-management classes, but also physician practices and providers and their staff are involved in this, and not only to refer beneficiaries to classes, but QIOs provide quite a bit of technical assistance to these practices in various areas. Community partners and stakeholders, we could not survive, basically, without their help, and it is very much appreciated. Senior centers, AAA sites, there's private and public grocery store chains, all types of partners. The QIOs also collect data that I mentioned previously, hemoglobin A1C and the diabetes measures, and then the sustainability and implementation of that. This is the slide of the triple aim. So most of you should be familiar with the triple aim. That was developed at the Institute of Healthcare Improvement on Berwick and Company, and it was developed as a framework to improve our healthcare system. So EDC runs along this framework, and I've outlined for you a little bit about how it follows that in terms of improving the individual experience of care, and then improving quality, and then the impact on cost. So we are trying to improve that whole framework. Okay. So how to accomplish EDC? Again, these slides are pretty full, but I mentioned recruiting and enrolling beneficiaries and classes. These classes are very basic. They teach healthy lifestyles, basic anatomy, nutrition, medication adherence. They're 6 consecutive weeks, 2.5 hours each class. And frequently guest lecturers are invited from the community. They can be pharmacists, dietitians. QIOs try to make this as culturally competent as possible, depending on the population who's enrolled in the class. Many classes are taught by community health workers, and if at all possible, classes can be taught in the preferred language of the population. And most of these classes are also been tailor-made for low literacy populations. What makes this also unique is family member or caregivers are encouraged to attend classes with the beneficiary. And it's, as I mentioned, not a one-size-fits-all. These are tailor-made classes for specific populations. In terms of physician practices, there are clinics, Medicare Advantage plans, FQHCs, rural health clinics. We welcome all types of healthcare providers to partner with. Okay. Community partners, as I mentioned, AAA sites, senior centers have been wonderful. Pharmacies, libraries, faith-based organizations, even police stations have hosted classes in rural communities. So wherever we can find a willing partner, we're happy. We're happy about that. And data, as I mentioned, I did not mention yet, though, each beneficiary completes a pre- and post-diabetes self-management education survey. We call it a patient activation survey, PAS. And that's another component of the data in addition to the clinical data. And that is so we can see from pre to post what the learning curve is, if we're reaching people. So I'll explain a little bit more of that in another slide. This just also goes over some of the sustainability planning. So Queens need to increase the numbers of certified diabetes educators, or CDEs, in their states, as well as the numbers of lay diabetes educators in their states. There is a Train the Trainer program that you can work with Queens and enroll in. There also the technical assistance provided to practices is not only in the areas of cultural competency and data collection and analysis, working with electronic health records, but also in establishing your own ADA or AADE recognized or accredited diabetes education program. By doing this, it enables the provider to bill for the Medicare Diabetes Self-Management Training, or DSMT, benefit. Okay, a little bit of EDC data. Now, these data are from not for the whole 10 years. This is from August 1st, 2014 through July 31st, 2017. So 38,388 beneficiaries have completed classes. Over 500 providers are working with QIOs in EDC, and this represents more than 7,000 individual physicians. So at different clinics and provider sites. The survey that I mentioned, so we've analyzed 1 year of the patient activation survey. This represented a little more than 10,000 Medicare beneficiaries from underserved minority and rural populations. From pre to post DSME, 14 questions showed statistically significant improvement responses. And I've given you the website there, the link, so later you can go back and see the full 14 questions. But this is just a little bit of a sampling of some of the demographics questions that we asked and what we found. 37% of the respondents were recruited to classes from senior centers, so we're, again, very grateful for our community partnerships. 53% of respondents had diabetes for 4 or more years, but 61% had never received diabetes education previously. I actually think that 61% is a little underreported because we asked them about diabetes education, but we don't want to get too granular in terms of what we mean by education. So we think that people are saying, well, my physician handed me a pamphlet about diabetes, so therefore I've had diabetes education. So this is probably a little bit higher than 61%. We're finding in classes that the majority of people have never had education before. Here is the literacy issue. 19% had 8th grade education or less. And interestingly, that 70% reported eye disease as the comorbid condition, the most prevalent comorbid condition. Now, usually we see hypertension, and the statistics, medical statistics bear that out, but this group, I don't know, it may be a reflection of also maybe they're more concerned about their eyesight. So we thought that was interesting. The classes have been taught to date in 13 different languages. The Train the Trainer program that I mentioned earlier, so the statistics from August of 2014 through July of 2017, over 4,000 trainers have been trained nationally, and these include community health workers, lay leaders, and sometimes nurses, registered dietitians, CDEs, pharmacists, and EMTs want to enroll in the training because they say even though they know the academic piece of diabetes, it's how to teach that we're teaching in these classes. It's a very unique way of teaching, a unique style. So we're happy that also licensed healthcare professionals are interested. And this is just a little bit of a sampling of the types of technical assistance provided by the QIOs. As I mentioned, it's also cultural competency, but identifying how to identify a population of people with diabetes, and then the latest, most current diabetes measures, guidelines, and standards of care. We find that these practices who serve these populations are very overwhelmed, so this is a nice reminder. And then this piece about sustainability, which I mentioned earlier. Okay. This is a resource slide. These are the links, and I think maybe later when you have time, if you want to go back and find out a little more about EDC, there's FAQs, the results of the survey, and we're in the process of analyzing the second year of survey data. That won't be available until probably early 2018. And we're also in the process of analyzing all of the clinical data that we've collected to date. So that QIOs were collected to date. Again, won't be available until early next year, but so there'll be more data coming. This is the fourth link I thought you would like because this is a nice tip sheet summaries that were developed by our NCC. And these are 7 Medicare preventive benefits having to do with diabetes as well as cardiovascular disease. Many practices, many practitioners aren't aware of all of these Medicare benefits, so this is a nice summary of them. And then how to locate your QIO, and then the CMS OMH equity plan. And my contact information is at the bottom. So this is my favorite part of the presentation, pictures. I wish I could just do pictures. EDC, this is an example of a flyer that one of our QIOs very cleverly made, trying to get across to people what diabetes is and why they should come. Many years ago, when I taught, before CDEs were around, nurses taught a lot of diabetes education, and my patients used to always say, I don't have diabetes, I just got sugar. So we thought that this would be a nice, a clever way to get people's attention. This is a very nice picture of a master trainer class in Texas. We wanted you to see the various, again, trying to build a healthcare force a workforce that would meet the needs of our vulnerable populations. Many of these spaces you can see are from the populations that we're trying to target, so very nice that we're able to have trainers who, again, with that cultural competency piece. This is a nice picture of a graduation ceremony in New York. At the end of each 6-week session, there is a graduation ceremony, and beneficiaries receive a diploma with a EDC logo. And many of them have told QIOs that this is the first diploma they've ever received in their lives. So it's a nice celebration of their achievement. This is a very interesting diagram of, again, appealing to low literacy. Most of these people have not had basic anatomy or any chemistry, so they don't know where their pancreas is, what it does, all of the cardiovascular involvement. So this was just made from a dollar store, some of the Velcro pieces, and you can actually remove them and hold pieces, anatomy in your hands, and that's been very popular among. This is a schoolyard with, in English and Spanish, you can see the big foot, I call it Bigfoot, in the foreground there on the table, and this was in New York, and they were at a health fair, and they were demonstrating how to do self-foot exams using monofilaments, and was a very popular line. I understand there was quite a line of people waiting for that. Hemoglobin A1C module, again, being very basic, demonstrating for people who have not had chemistry. How to check your blood sugar in English. Here's Spanish foot care poster. And I just want to thank everyone. I know that was a very quick, high-level overview, but we'll have time later for questions. And as I said, you'll have the slides at your disposal later. So thank you very much.
Thank you, Sue. It is now my pleasure to introduce Dr. Kate Curley, the Director of Chronic Disease Prevention, and Ken Henriksen, Director of Physician Engagement and Health System Engagement with the American Medical Association. Kate and Ken will discuss the implementation of identification and referral processes for diabetes prevention. Kate, Ken, we really appreciate you being on today, and the virtual floor is yours.
Thank you so much, Lindsay. We are so excited to be here because this is our favorite topic, discussing how healthcare providers and practices and systems can implement identification and referral processes to prevent diabetes. And I think we are just waiting for Sue to pass the ball over so we can continue our...
I'm looking at my screen, and I'm trying to find the participants have disappeared. So how do I get the ball? Let me see. Oh, a little bit of technical difficulty here. Okay. I couldn't find the names. Okay, let me...
And while we figure that out, I can actually talk briefly for a moment because I don't know that we need our slides for the first couple of points, which are that we just want to share with everyone that we have no relevant financial relationships that we need to disclose. We will show that slide as well. And then why don't I outline sort of our objectives for our portion of the call today. We will be sharing with you all the AMA strategy to prevent type 2 diabetes and how we work with clinicians and practices to implement some of these processes to identify our patients who have prediabetes and refer our patients into effective preventive interventions, specifically the Diabetes Prevention Program. And we'll highlight as well some of the key considerations that organizations may want to be aware of regarding the upcoming coverage, Medicare coverage specifically, of the Diabetes Prevention Program. And before we do that, I'll share a bit of information kind of shaping the clinical context about diabetes prevention, discussing the evidence base for interventions that do successfully prevent diabetes, to sort of give that clinical context and that background. So thank you, Ken. It looks like we've got our slides moving forward now. And why don't we sort of kick off with a clinical case that I think will put this in a little bit more context. I know everyone on the call is very familiar with the condition of diabetes, but I want to remind everyone sort of what is involved from the clinician standpoint when it comes to taking care of patients who have diabetes and why we want to get ahead of this condition. So this is Frank. You can see him laying on that bench there, I think waiting to catch his bus to go to work. And Frank actually is diagnosed with prediabetes at the age of 55. And his physician does what many of us do. I'm a primary care doc. I'm a family physician. We tend to tell our patients that they are at higher risk for developing diabetes, and we tend to counsel our patients that they really need to change their diet, get some more exercise. And, you know, Frank, he tries his best, like many of our patients do. But unfortunately, a few years later, he goes on to develop type 2 diabetes. And again, let's kind of come at this for a moment. We know that this is, you know, obviously a very upsetting diagnosis for Frank as an individual, but let's come at this for a moment from the clinician standpoint. Let's think about all of the stuff that we now have to do to take care of Frank. And this is just that first diabetic visit there. So, of course, we have to talk to Frank about his diagnosis, explain what that means. That alone could take up our entire visit. But we also need to do all these things. So we may need to prescribe a glucometer for Frank, and of course all the supplies that go with it. And Frank probably has no idea how to use his glucometer, so we're going to refer him for some good diabetes education. Hopefully he's going to get some good diabetes self-management training. We probably need to start him on metformin. Of course, that's a significant conversation with significant counseling needed. He may need to start a statin, most likely. Does he need to start aspirin? That's a whole thing to figure out. What about an ACE inhibitor? Does he have hypertension? He needs to get referred to nephrology. He may need to get referred to podiatry. I get out of breath just talking about this. And we're supposed to fit all of this into a 15-minute visit. And, of course, he probably has other comorbidities that we need to deal with as well. And we need to keep doing this with Frank, right, about every 3 months. Ongoing labs, ongoing monitoring. So this is a lot for us to take on. So Frank, you know, he does his best with his diabetes, taking care of his diabetes. But a few years later, he still goes on to develop retinopathy. Sorry, a couple technical difficulties here with advancing our slides. I apologize, everyone. We seem to be unable to advance our slides.
Maybe I'll give the ball to Nikki. Nikki, should I pass the ball back to you?
Sure, Ken. That'll be fine.
Apologies, everyone.
Okay, Nikki, you have the ball.
Great. And Nikki, go ahead and advance again, please. So he develops retinopathy. He goes on to develop chronic kidney disease, and go ahead and advance. And along with that chronic kidney disease comes another pile of stuff that we're going to do to take care of Frank. And plus he's developing additional complications at this point that we're going to need to manage. And go ahead and advance again for me, Nikki. And really the sort of devastating outcome that ultimately happens to Frank is he has an MI and he dies. And this is horrible for Frank's family, and it's also extremely demoralizing for us clinicians who are taking care of patients like Frank. Next slide. Now, if we don't get ahead of this condition, then what we can expect to see is that the typical physician practice will be taking care of 32% more patients with type 2 diabetes 5 years from now. And so as a primary care doc, I find that absolutely overwhelming, and the AMA believes this is just absolutely untenable, and that's why our organization is focused on this issue. Next slide. And so the way we believe that we can get ahead of type 2 diabetes in the clinical setting is to begin focusing more on prediabetes. Just to remind you all, prediabetes is this condition, a typically reversible condition, in which plasma glucose levels are higher than normal, but they're not yet high enough to qualify for a diagnosis of type 2 diabetes. We can diagnose it with a fasting plasma glucose or a hemoglobin A1C test or an oral glucose tolerance test. Next slide, please. We know that we have an epidemic of type 2 diabetes, right? We have an estimated 30-plus million Americans who have type 2 diabetes, but that really is just the tip of the iceberg because we have an estimated 84 million American adults who have prediabetes. So that's about 1 in 3 adults in the United States. And if we look at the population of folks over the age of 65, roughly half of that population has prediabetes. And actually 9 out of 10 of these individuals who have prediabetes do not know that they have it. So that makes it very difficult to intervene upon them. Next slide. So I do want to offer that we believe there is a very effective evidence-based solution and intervention that we can offer our patients who have prediabetes. And that intervention is an intensive lifestyle change program in the form of a diabetes prevention program. So what would your patient with prediabetes experience if they were to participate in a diabetes prevention program? So this is, as I said, an intensive lifestyle change program. It's typically delivered to folks in a group setting, and individuals attend these group sessions that take place on typically a weekly basis over the first 6 months of the program, and then typically a monthly basis over the second 6 months of the program. So I wasn't kidding when I said intensive. It is a year-long program. And these group sessions are led by a trained lifestyle coach. Now, this coach can actually be anybody. They can be a licensed healthcare professional, or they can be a lay individual. The key is that that coach needs to undergo specific training to become a lifestyle coach, and they need to deliver a curriculum that is approved by the CDC. And this curriculum is very comprehensive. So, of course, it involves a lot of components about healthy eating and physical activity, but it also covers topics like sleep and stress management. And I think most importantly, it teaches participants the skills that they need to successfully make these behavior changes and to make these changes in a way that is sustainable in the long term. Next slide. So the diabetes prevention program is very evidence-based. It's founded in the randomized controlled trial that was conducted over 15 years ago now. And what we saw in this 3-arm randomized controlled trial was that individuals who participated in an intensive lifestyle change program, what we now call the DPP, they had a reduced incidence of type 2 diabetes of 58% relative to placebo in 3 years. I think it's hard to think of anything that we do in medicine that is this effective. Now, in this trial, they also looked at using metformin for preventive purposes, and I should note that metformin is not FDA approved for this indication, although it is fairly well studied. And what they saw in this trial was that metformin also reduced the incidence of type 2 diabetes by 31% relative to placebo. So it was very effective, but about half as effective as that intensive lifestyle change program, the DPP. Next slide, please. And so we have such a burden of evidence at this point demonstrating the effectiveness of this program that it's now being incorporated into current clinical guidelines. So this slide here depicts the United States Preventive Services Task Force recommendation regarding screening for abnormal glucose. And here we see who we're supposed to screen, specifically people between the ages of 40 and 70 who are overweight or obese. But the screening recommendation does not stop there. It goes on to say that if we identify individuals with abnormal blood glucose, we should be referring those folks to intensive behavioral counseling interventions. And so what that means is that if we identify an individual with prediabetes, we should be referring them to a diabetes prevention program. Next slide. And so now that I've reviewed sort of the clinical context and some of the evidence behind this program, I'm going to hand it over to Ken to tell you a little bit more about the AMA's strategy and how we work with practices to implement screening and referral.
Very good. Thank you, Kate. Kate has provided you with the clinical evidence to address diabetes prevention and the evidence-based solution to effectively mitigate the prevalence of diabetes, and that being the National Diabetes Prevention Program. I'm going to spend a few minutes this afternoon sharing with you the AMA's approach and the dedicated efforts that they have through our Improving Health Outcomes area to prevent type 2 diabetes in line with the AMA's goal to improve the health of the nation. Next slide. So beginning in 2003, following a strategic review that was undertaken by AMA leadership, the AMA pivoted a good portion of their focus to three strategic areas within the organization. I'm going to highlight each of these briefly. One of this is an area that's called physician satisfaction and practice sustainability, which is designed to improve physician satisfaction with the practice of care, helping physician practices thrive. Another of these strategic areas is accelerating undergraduate medical education, which is the component of our strategy, creating the medical school of the future. And then finally, the area that Kate and I reside in, and where a lot of the strategic focus around diabetes prevention resides, is in the improving health outcomes area, where we are looking to shift the focus on preventive health and improving patient health. The framework that we use to engage in this work is around a vision that we have to improve the health of the nation by preventing chronic disease. And with this, we have a mission, an audience, if you would, to engage all primary care physicians, care teams, and patients in taking action to prevent chronic disease. And then finally, with these initiatives, we have key activities around set objectives to build partnerships with external entities that are committed to the same mission and vision that we have, to remove the barriers to effective implementation of prevention, and to increase awareness among healthcare practitioners and care teams of the value of the focus on prevention and not just on treating disease. Next slide. So the central partnership that the AMA engaged in to do this work around preventing diabetes is a partnership that we've been engaged in since 2013 with the Centers for Disease Control and Prevention. The AMA is pleased to be a partner with the CDC with the objective of increasing awareness among physicians and care teams about the condition known as prediabetes, increasing knowledge of the diabetes prevention program and the effectiveness of this program in reducing type 2 diabetes. We also work on increasing the referral of eligible patients to practitioners, by practitioners, into CDC-recognized diabetes prevention programs. In 2015, our collaboration resulted in what is defined as a call to action, Prevent Diabetes STAT, Screen, Test, Act Today. Through our combined efforts, staff from our two organizations developed and implemented the Prevent Diabetes STAT website, which is visualized here on this slide, which houses information and resources for patients and partners, healthcare professionals, and employers and insurers to take action to prevent diabetes. You can notice that the URL to access this information is noted at the bottom of the page. I would encourage all of us who are on the line today to access the website and review this rich content to assist your organizations in your work to prevent diabetes. Next slide. So I want to spend just a minute reviewing the services and support that the AMA and the staff in the Improving Health Outcomes area provide to healthcare organizations to identify a diabetes prevention strategy within their organization and to put in place a diabetes prevention program for their eligible patient population. Next slide, please. So over the past 3 years, the AMA has been working hand-in-hand with project teams and interested healthcare organizations to implement the CDC-recognized diabetes prevention program to support the patients that they serve. The AMA staff provide a comprehensive program to guide the implementation of practice change in order to prevent type 2 diabetes. We offer services that assist an organization in doing technical implementation of a diabetes prevention program, that assist in engaging their physicians and care team members in awareness and education about diabetes prevention program and the diabetes prevention program curriculum. And we also provide consulting support to organizations who are in the interest of learning more about what other organizations are doing around diabetes prevention and assisting them in doing action planning and implementation within their organizations. We have core decisions that they need to walk through as an organization in order for them to stand up an effective program. And we marry the tools and resources that are out on the Prevent Diabetes Stat website with the work that we do in implementing and working with the implementation team. Next slide. We also have a series of specific tools and resources that we provide, and I'm just going to share a highlight of a few of these. A central component of this work is to increase awareness about prediabetes and the diabetes prevention programs among physicians and care teams. And a good amount of the work that we do is to roll up our sleeves and work individually with organizations to take the tools and resources available on Prevent Diabetes Stat and to translate those into a physician engagement plan within their own organization that fits the way that they communicate with their physicians on new transformational activities. Next slide. Next slide. So we also spend a good amount of time working with organizations to identify the eligible patients who have the condition known as prediabetes who would be candidates to participate in the diabetes prevention program. And even organizations who are not necessarily ready to put a diabetes prevention program solution in place, we actually encourage them to identify their eligible population so that they at least have a sense for the prevalence of prediabetes among their patient base. Next slide. And then we also have tools and resources and engage in organizations in developing a patient communications plan and use the tools and resources that are out on the Prevent Diabetes Stat toolkit in order to do so. We would welcome the opportunity to work with interested healthcare organizations in implement a diabetes prevention program within their organizations and refer patients to a CDC-recognized program. And we would encourage any of you who have an interest in doing so within your organizations to reach out to us here at the AMA. I'll now turn the program back over to Dr. Kate Furley, who share with you an update on Medicare coverage for the diabetes prevention program, and I believe we're ready to move to the next slide.
Yep, thank you. And next slide, please. We're very happy to report that CMS has finalized that it will begin covering the diabetes prevention program to eligible Medicare beneficiaries. This is actually the result of a CMMI demonstration project led primarily by the YMCA that the AMA had the pleasure of supporting. And what we saw in this CMMI demo was that, and by the way, the purpose of the demonstration was to test the delivery of the diabetes prevention program to Medicare seniors. And what we saw was that not only did the diabetes prevention program improve the health of the Medicare beneficiaries, it also saved CMS money to the tune of $2,650 per participant over the course of 15 months. And so because of both the improved health outcome as well as the cost savings, Medicare is expanding this demonstration to all Medicare beneficiaries who meet the eligibility criteria. Next slide, please. And just a couple quick details about this Medicare coverage. The coverage for the program will begin on April 1st, 2018. A couple notes about beneficiary eligibility to participate in the Medicare diabetes prevention program. Individuals will need to have an elevated BMI as well as the lab results within the pre-diabetes range, which is noted there on the slide. They also must not have a previous diagnosis of diabetes and no current diagnosis of end-stage renal disease. And the set of services that Medicare will be covering is the traditional one-year-long program, which I described earlier. And for those individuals who are able to achieve the 5% weight loss, they are eligible for up to an additional 1 year of maintenance sessions provided they're able to maintain that weight loss. So just a couple of details there about Medicare coverage of the diabetes prevention program coming next year. Next slide, please. And that wraps up what Ken and I have planned to share today. I believe we have a facilitated discussion and question and answer happening now. I will turn it back over to Lindsay, who will be leading us through the next portion of the call.
Thanks, Kate. Thank you, Ken. Unfortunately, we're running a little behind on time, so we are actually going to save the discussion for after Joan's presentation. So you'll all just hang tight and keep putting your questions in chat. We will get to them after we hear from Joan. So it is now my pleasure to introduce Joan Bardsley, Assistant Vice President at MedStar Health Research Institute. Joan will discuss the utilization of the Diabetes Self-Management Educational and Support Joint Physician Paper and Algorithm in the care of those with type 2 diabetes. Joan, we appreciate you being on today. The virtual floor is yours.
Thank you. I'm absolutely delighted to be here today to talk about a topic that is very near and dear to my heart. What I'm going to be focusing my remarks on is using the Joint Physician Paper and Algorithm of Care in the care of those with type 2 diabetes. And what is so important about this presentation and about the algorithm that was developed is it was absolutely done in collaboration with 4 major organizations: the American Diabetes Association, the American Association of Diabetes Educators, the Academy of Nutrition and Dietetics, in addition to support with the National Diabetes Education Program. When it was published exactly at the same time. It was dropped online during the American Diabetes Association annual meeting in 2015. So I am just very excited that this is one of those initiatives that was supported in a very large sense by the key organizations who deal with diabetes and diabetes education. One thing that I do want to point out is that the nomenclature describing diabetes education has actually changed. It changed this year. When the National Standards for Diabetes Self-Management Education was reviewed, when those were reviewed, it was decided that there wasn't enough focus on the support that those with diabetes need. In addition, there wasn't really a focus on pre-diabetes. So the nomenclature changed just this year, so you'll, as opposed to seeing diabetes self-management education, you'll hopefully see more reference to diabetes self-management education and support. And the definition is listed there as the ongoing process of facilitating the knowledge, skills, and ability necessary for pre-diabetes and diabetes self-care, as well as the activities that assist the person with diabetes or pre-diabetes in implementing and sustaining the behaviors. And the key is on the behaviors, because that is what is needed to manage his or her own condition on an ongoing basis, outside of the formal self-management training. So for the purpose of this presentation, I will still use the DSME to protect the references that I am going to be using, but hopefully you will see the DSMES in future presentations. Okay. When we're looking at diabetes self-management education, we really have to look at why are we doing it? What are the benefits associated with it? And we have to look at the evidence that is there. We're all scientists, and we have to make sure that we are basing our recommendations on science, and that is what we have found with education. We know that if someone has engaged in diabetes self-management education, that they will have improved health outcomes, that the A1Cs can be reduced as much as 0.88%. There is a reduction of the onset and advancement of complications, which of course affects quality of life as well as costs. There is reduced hospital admissions and readmissions, and a particular focus on emergency department visits. There's also increased medication adherence. There's more healthful eating patterns and regular activity, and I'll go through those in a few seconds. But really key is looking at the patient, the person who has diabetes. Are they able to feel empowered to take care of their disease? Are they able to cope in a healthy way with having diabetes? And what is their quality of life? One frequently referenced paper is that from Norris in 2001 that really taught us that the benefits of education decrease over time. It's not just a one-time intervention that will sustain over a long period of time. We also know that it requires time and follow-up, and that the effectiveness directly is correlated to the amount of time spent with the educator. So you might say, well, it's 2001. Well, we do have updated evidence that we will go through also. And this was confirmed, and this happened in August 2015. The paper was published because a systematic review was done looking at the impact of diabetes self-management education on glycemic control in adults with type 2 diabetes. So it really said, has the evidence changed? What do we really need to look at to ensure that we are providing education that is consistent with the evidence that is out there? So the question really arose that does diabetes self-management education improve glycemic control as measured by A1C in adults with type 2 diabetes as compared to those who received usual care without diabetes self-management education? And what we found was that it absolutely did. When you're looking at the results, one of the things that was really focused in on how is education delivered, because that was really important, and we'll talk about the barriers that are associated with getting education, but one of them was, what does it look like? What is the best method of delivering diabetes education? And what was found that with all models of care together, whether it's a combination of group and individual, or group alone, individual alone, or actually remote access, that when you combine all of those, there's an absolute difference in A1C of about a decrease of about 0.57. However, if you combine group and individual, there's a reduction in A1C of 0.88. So a much greater reduction. Now, you would also question, well, what about remote? We're hearing a lot about this. When you look at the time frame in which this was done, when you look at August 15th, and of course the papers were reviewed much before that, we didn't have a lot of evidence at that particular point, but we are getting more evidence now, and I would suspect that the remote access is also going to contribute even greater amount to the reduction of A1C. So what did the systematic review teach us? That engaging adults with type 2 results in statistically significant and clinically meaningful improvement in A1C, that the group and individualized engagement really is the best method. So that combines individual assessments where the patient would really have that one-on-one time and yet have the group support that will be critical in managing their diabetes going forward. There's also evidence to show that when a team rather than a single individual is involved in the provision of education, everyone will bring their area of expertise. And so that was an important learning. And then we also found that those receiving more than 10 hours of DSME had a greater improvement in A1C. So the question begs, why was 10 hours chosen? And the reason that 10 hours was chosen is that Medicare currently reimburses 10 hours in the first year that the benefit is used for type 2 diabetes, and then 2 hours afterwards. But unfortunately, the evidence shows that more than 10 hours is needed in order to have the benefit. So it's one of those situations when the benefit was conferred that the evidence wasn't as striking as what we know now is important. So the challenge is to match the benefit from Medicare with what the evidence shows has a greater effectiveness for education. There is a sorry state, though, of diabetes education. What we do know is that about 6.8 of individuals with newly diagnosed type 2 with private health insurance received DSME within 12 months of diagnosis. And we also know that 5% of Medicare participants receive diabetes self-management education or medical nutrition therapy. And I will quote a colleague of mine who points out very readily that under 7 is actually quite excellent for an A1C, but it is not good for those who are receiving education. So this is the needle that we really have to move to make sure that participants or those who have diabetes will actually have their education benefit utilized so that they can improve their health care. So this is a challenge for all of us. Why doesn't it happen? We'll say we know that it works. Why doesn't it happen? First of all, the time that it takes to receive education, the location. Where is it available? How close is it to where someone is working? Are the classes only during the day? is a referral necessary? And right now, a referral is necessary in order to get the benefit covered. That also brings us challenges. Who's writing out the referral? Do physicians know to write out the referral? Hopefully with electronic health records, it may be very helpful, and I know some systems are looking at that there's an automatic referral for those who have diabetes to the education program, so more of an opt-in program than an opt-out. So hopefully we'll be seeing more of that. We have to look at diversity, that when we're looking at doing diabetes education, we have to make sure that it's not one size fits all, that we're actually customizing, individualizing to what the individual needs. There's value confusion. How important is education? Is it only important when someone is starting on insulin, which is often happens, or is it important from day one so that people can really have a comprehensive ability to manage their diabetes? There are not sometimes clear expectations on what happens when diabetes education does occur, and of course we always have to look at cost and reimbursement. So, the American Diabetes Association actually comes out with standards of care, and these standards of care are published in January of every single year, and it incorporates the latest evidence that is available that talks about how we should be caring for diabetes. And the evidence actually is pretty compelling that all people with diabetes should participate in an education program, both at diagnosis and as needed thereafter. An individualized MNT program is recommended as an effective component of the treatment plan. This education needs to be patient-centered. We have to focus on what the individual needs are of each person with diabetes. We have to be respectful and responsible to the patient's preferences, really incorporate how diabetes is incorporated into their lives so we're not changing everyone's lives to manage diabetes. And that medical nutrition therapy and education can result in cost savings and improved outcomes, and both should be adequately reimbursed by third-party payers. So these standards of care in 2015 really looked at what the standards of care were, and it was included in 2016, the Joint Position Paper. So it has become a standard of care. And the algorithm is pictured here. It's 2 pages. You can use this as a freestanding document, and we'll go through what the algorithm of care really says. The purpose of the position paper really was to improve patient experience, improve health of individuals and populations, and reduce per capita health care costs. So that's not something new that we know, but it's something that the position paper really focused on. It was also going to provide healthcare teams with information to better understand the educational process and really what should be expected. What should providers expect when they refer the patients to diabetes education, and how do they integrate that into the routine care? And on a very practical level, it was to create an algorithm that defines when, what, and how it should be provided with adults with type 2. Okay. So, again, this is what it looks like. It's a little bit bigger in this particular picture. And it really underlines that education is critically important, but it does not mean that we don't focus on nutrition and on emotional health. Those things all have to work together in order to give patients the knowledge, have the support, and have the very specific nutrition guidelines that are there. What you will also see are the 4 times when education should be delivered. And we will go through each of those. Underlying this and supporting all the education are the AADE, the American Association of Diabetes Educators, have identified 7 self-care behaviors as a framework for patient education. And I'd like to point out a few of these. First of all, healthy eating. I would like you to note it does not say diabetes diet. Okay? It does not say diet at all. It says, how do we encourage our patients to eat healthy? The second one is being active. It deliberately does not say exercise. It's broader than that. It's how do we encourage people, including exercise, but including general activity? How do we get people moving so they can really help manage their diabetes? It talks about monitoring, such as blood glucose monitoring, focus on taking medications, problem solving. How do you deal with problems that come up each and every day? Healthy coping, because we know patients who have diabetes have an increased risk of both depression and diabetes distress, as well as the seventh one is reducing risk. What kind of behaviors are people using that will contribute to complications, and how do we reduce those risks? So, the 4 critical times to assess and provide and adjust diabetes education are listed there. It's first of all a diagnosis. When someone is diagnosed with diabetes, there should be a referral for diabetes education. Even if someone is on diet alone, or if on just looking at a meal plan, or if they're taking metformin, it doesn't mean that they shouldn't be referred. How do they learn about the disease? How do they learn to best manage from day one? The second one is annually. As patients are seen on an annual basis to see their provider, they should also be assessed at that point for how they're doing with their diabetes. When complicating factors occur, such as complications, and when transitions in care occur. And the whole idea of this is that it really looks at the continuum of care. It looks over the entire lifespan of a person with diabetes and the different things that should occur at the different times that things should be assessed, because it's very different at each of these times on how diabetes is managed. So, at diagnosis, it should be a focus on all people with diabetes, but you have to include the emotional health and nutrition. What happens at the education visit is to give some guidance as to what should be expected. Cultural influences should be looked at, health beliefs, current knowledge. What are some of the aspects that people know about? Is it accurate? Physical limitations that may cause a person with diabetes to not be able to be active or best control their diabetes. Is there family support? What's the financial status, medical history, literacy, numeracy, etc.? So that all of those things in the assessment really guide how to provide and manage medications, glucose, activity, chronic complications, psychosocial issues, health and behavior change. As you can see from this, it is more than just talking about a medication that is given. It's a much more comprehensive and holistic approach to the person with diabetes. The second time is at an annual, when someone is being seen annually. That might be a time when someone has had no prior education. They've seen their physician on an annual basis, but they haven't had any previous education. There might be a change in medication needed. There might be more advancement. Has there been clinical inertia problems that the patient is not on the proper dosage? Is the hemoglobin A1C out of range? Are they doing well? And if they are doing well, let's support that. Let's really look at positive health outcomes so people understand the work that they're doing to manage their diabetes can help. Are they planning a pregnancy? Is just support needed at that time? Are there weight issues, or are there new life situations that need to be addressed? So at that annual visit, these are some bullet points that can be looked at to reinforce the treatment goals, emphasize preventing complications, learning how to adapt to diabetes treatment, and support efforts to sustain the initial behavior change. People are often scared of diagnosis and make some behavior change, but it wanes over time. So how do we make sure people are sustaining what they know they need to do in order to manage their diabetes? Because knowing what to do and making those changes are certainly two very different things. When complicating factors influence self-management, it's another time to refer for education. These could be health conditions, physical conditions, emotional factors, or basic living needs. And again, the algorithm provides very specific but broad guidance on what should be done during those education visits, looking at providing support, looking at providing referral for emotional support for diabetes-related distress or depression, which again is very high in those with diabetes. What kind of personal support strategies are needed, and really looking at ways to adapt to sensory and physical limitations, new self-management demands, and promote health and behavior change. And then the fourth time the referral should be made for education is when transitions in care occur. And that could be a transition in a living situation. Is a person moving out of the parent's home for the first time, or a parent moving into someone's a younger child's home, and the family needs to know how to best take care of diabetes. When there's a transition in care from the medical care team, when they're going from one insurance to the other, and so there's a good time for assessment. And if there's age-related changes that occur that will require reassessment of how the patient is managing their diabetes. And again, it gives very specific yet high-level guidelines on what to cover during those education visits. And it's important that the providers, again, actually know what should occur during this particular time. And so I'd like to conclude that the challenge for many of our providers and for all of us is, if diabetes self-management education were a pill, would you prescribe it? And this was taken by Maggie Powers during her presidential address at the ADA. And I think it really made us stop and think for a second. If you're looking comparing the benefits of DSME to the benefits of metformin, you will see that they both have high efficacy, low risk of hypoglycemia, weight is neutral, or there could be a loss. But I would like to point out there's absolutely no side effects or adverse events that are associated with education, where metformin may have some GI effects. The cost of diabetes education is low, and there's actually savings that can be occurred by having people involved in education, where the cost of metformin indeed is low. Critically, though, the psychosocial benefits of referring someone to an education program and having people empowered to take care of their diabetes are extremely high and contribute greatly to the quality of life. So, thank you on behalf of the patients we serve, and I think I will send this back to Nikki, who will take us from here.
Thank you very much, Joan, and thank you all to our presenters. A lot of great content covered today. We are now going to have some time for discussion and Q&A. I think we should probably start with some questions in the chat. So, Susan Burtman, I'm going to just ask you to help facilitate this part of the discussion.
Sure. Thanks, Lindsay. We do have a couple of questions related to prediabetes, and the first one is, what do you use to determine prediabetes, and do you use A1C and fasting?
Yeah, thank you for that question. You can use either or. So a hemoglobin A1C or a fasting glucose or an oral glucose tolerance test are all valid options to use to diagnose prediabetes.
And so the follow-up to that question is that the information studies found about it can be contradictory. Which one would be the best test to diagnose?
So AMA doesn't recommend one over the other. And I think really what we've seen in the studies is that all of these different tests identify potentially slightly different but overlapping populations, and all of these individuals who have an elevated, whether it's fasting glucose A1C or glucose tolerance test, are at increased risk for progressing on to develop type 2 diabetes, and are individuals who can potentially benefit from intensive lifestyle change. One thing I will say is that in the era of querying our EHRs and developing reports to identify our populations of patients who have prediabetes, the hemoglobin A1C certainly has the advantage of being an easier data point to use in report generation. It's very difficult to determine oftentimes whether a glucose measurement in an EHR is a fasting measurement or not. So from that perspective, an A1C may have advantages, but from a clinical standpoint, we don't recommend any one over the other.
Great. Well, another question related to A1C is, do you know how far back it's acceptable to use an A1C that's greater than 5.7?
Yeah, that's a great question, and I think in some ways, it's a judgment call on the part of the clinician. Typically, we advise repeating the laboratory test if it has been longer than 1 year. In reality, folks that are at the higher level of that A1C range or that fasting glucose range are at higher risk of progressing to type 2 diabetes more quickly, and so it's reasonable to consider repeating a test if it's been more than 6 months, but ultimately it's really up to the clinician.
Thanks.
So the next two questions are related to the DPP. How many beneficiaries are currently participating in the DPP? And what has been your total for your outcomes presently?
So if we say beneficiaries, I'm not sure if that question is in regards to Medicare specifically. I can say that with the CMMI demonstration project that was conducted, there was, I believe, over 5,000 beneficiaries that were enrolled in the program through that. In terms of the number of participants in the National Diabetes Prevention Program overall, the CDC is sort of the central collector of all of that data. And actually, I do not recall off the top of my head the number of individuals who have participated in that program. Oh, Ken is mouthing to me that it has been approximately 150,000 have now enrolled in the diabetes prevention program.
Based on data that was presented recently at a event that I attended, approximately 150,000 individuals have completed the program to date.
And CDC recently published the participant level results outcomes from the National Diabetes Prevention Program in an article in Diabetes Care earlier this year.
Great, thanks. And so this question is about coverage of the DPP program. How long do you think it will take private insurance to cover DPP?
So AME and CDC are working on this issue together. And actually, we already have a number of commercial insurers who do cover the program. It varies widely across geographies and payers and plans. What I can say is that we are seeing increasing coverage of the program because it does demonstrate the clear cost savings. But I don't personally have a prediction for when we will have, more universal coverage for the program. But we encourage clinicians to let their payers know that this is something that they would like to use and that their patients would like to access. And we encourage everyone to send that message.
Excellent. One more thing related to the program. It looks like a participant was told to use the risk assessment test to qualify participants for the program, but can only have half of their participants on the risk assessment. Is that true?
Yeah, so that's a great question. So if we are talking about the National Diabetes Prevention Program, and we're not talking specifically about Medicare beneficiaries, so right now I'm excluding Medicare, then an individual can be eligible to participate in a program if they have the elevated BMI and they have an elevated score on the risk test, and you can find the risk test on the preventdiabetesstat.org website as well as CDC website. So yes, the risk test plus that BMI is sufficient to be eligible to participate in the program outside of Medicare. Medicare will be requiring that lab test diagnosis, though, so the risk assessment alone will not be sufficient to qualify a beneficiary to be eligible to use that service. And then your note about half of participants can gain access to the diabetes prevention program via that risk test. That is true. So if we're a given diabetes prevention program provider, up to half of their participants can qualify based off of that risk score and BMI as opposed to needing that blood test.
Great. Well, we do have a few more questions from the chat, but I do want to give the call participants a chance to dial in their questions.
Yeah, thank you. Tiffany, would you remind our participants how they can call in for a question?
As a reminder, to queue up for a question over the phone, please press star followed by the number 1 on your telephone keypad. We will pause for just a moment to compile the Q&A roster. Again, that is star 1 to ask a question.
While we wait on that one, there's kind of a follow-up to the DPP program. If a participant's A1C has improved over the year prior to that, but they still want to participate for the lifestyle change and benefits, would they be able to continue?
So So if an individual's A1C reverts back to normal over the course of participating in the program, they can continue to participate, and in fact, we love it when that happens. So the key is sort of their status at the time that they start the program, and that's what determines their eligibility, and then they can remain in the program throughout the entire program, even if their A1C reverts to normal.
You have a question from the line of Elda Brown. Your line is open.
Hi. My question is getting support from the AMA. We have not yet gone into a healthcare provider's office to discuss, NDPD program. What kind of level of support could we expect if we were to contact AMA?
So thank you for that question. What the AMA and the staff at the AMA essentially do is they work with organizations who have already made a decision that they would like to address this condition known as prediabetes among their patient base. And we actually work with them on basically sorting through the various data gathering that they do as an organization to decide strategically what type of program they want to have, whether they want to develop a program and stand it up within their own four walls, or whether they wish to use a community-based CDC-recognized diabetes prevention program that may be in close proximity to the organization's facilities, or whether they wish to engage in using a virtual diabetes prevention program solution where they actually would have the ability for their participants to do the program via computer through a computer-based training program. Once the organization makes that decision, what direction they would like to provide a program, then we actually work with them through a series of work streams to stand up the program based upon the direction that they wish to take as an organization. So we serve in a consulting capacity to them through the planning and implementation stages to the point where they actually conduct their first class. It's about a 4-month process from start to finish, generally, for an organization to put a program in place on their own. And we provide with them working in through a sequenced process and engaging with them in project team meetings on an approximately 3 to 4 week basis. The knowledge and the assistance that they need to stand up the program in their own organization. It's a no-cost service that we provide to organizations that wish to do so, and really work within the needs of the organizations that we work with to get to the goals that they wish to get to.
Great. Thank you so much.
Your next question comes from the line of Coleman Catton. Your line is open.
Hey, this is Coleman Catton. I'm calling from Alaska. So I've actually been trying to work on a program throughout the last few years through the Alaska Pharmacists Association for pharmacists in community pharmacies to treat prediabetes. Now, one of the big barriers is that's reimbursement, but are you familiar with any other states or anyone doing that, or I guess what are your thoughts? There's this push for pharmacists to treat diseases that require no formal diagnosis or limited diagnosis criteria. We only have 5 endocrinologists in the entire state, so that's another big barrier. What's everyone's thoughts on that?
Yeah, that's a great question. So I don't know specifically of anything happening in Alaska that I can point you towards. I can share that there are some Medicaid demos in a couple of states that I believe are wrapping up, Oregon, Maryland, that may provide a little bit of insight there. We are also seeing some states begin to cover this program for their state employees. And so I wonder if there could be opportunities there. But we'd be happy to connect with you to discuss that in a little bit more detail. The AMA does have a team of folks working on reimbursement.
Thank you.
Your next question comes from the line of Edwin Huff. Your line is open.
Thank you. I wanted to ask the presenters if they would be willing to address what appears to me to be a tremendous gap between what our agency at CMS is dedicating itself to and providing DSME self-management classes for known diabetics and the DPP program that you're speaking of, and its kind of conceptual startup for pre-diabetics. Am I missing something? But there are a lot of other people that are type 2 diabetics that don't seem to be in the crosshairs of either of those two programmatic efforts. Is this something that could address that huge pool of people to help slow their progression, reduce their complications and costs, and improve their quality of life and self-management?
Hi, this is Joan. I'll take the first stab at that. You absolutely identified the crux of the problem, and I touched on it briefly when I talked about some of the barriers that are there, and so it's programs like this. It's really having people understand that referral for an education program can be critically important in improving outcomes. Having education as a standard of care for diabetes and having it listed under the standards of care with diabetes hopefully will really make it important that people recognize they're not meeting the standard of care unless they are referring people for diabetes education. So it's really increasing the awareness and making sure that those who are referring, who take care of patients, providers who take care of people with diabetes are actually making that referral. You know, we are still referral-based in order for people to be able to access that benefit in the intervention. I would love to hear from my colleagues from the on the medical side on that question too.
I'm not sure that we have much to add from the AMA perspective. Okay. I don't know if Sue or anyone at CMS has any comments there.
Yeah, hi, this is Sue. Hi, Ed. Yeah, I mean, I think there's no doubt, as Joan and all of us agree, that the need is there. The issue comes with in order to totally revise the Medicare DSMT benefit, this has to be, all benefits have to be congressionally approved. So it's a process that has to take place through Congress to allocate the funding for the benefit through the Medicare Trust Fund. The funding for the DPP, the prevention benefit that has been spoken about today, is coming through the Affordable Care Act, two totally different buckets of funding. So they are different. I know it's going to confuse people next year for a while when the DPP first comes out. And that is, I think I saw a question in the chat room about Medicaid. The DPP that we're referring to is for Medicare only. Medicaid is state-based, so whatever the states choose to, individual states choose to cover, that's a different discussion. But, so, yeah, it's definitely a need. I don't think anyone debates that, but it's a matter of how can we get this in front of Congress and get the benefit revised.
Thank you so much, Sue, and to all of our presenters. This is Lindsay at the Quinn NTC, and we are going to have to stop here just to make sure we're respectful of everybody's time. So if you have any last questions, please feel free to submit them through chat, and we will try to post responses to any unanswered questions on the event page on the QAO program website if needed. And just a reminder, upon closing the WebEx session, you will be invited to share your thoughts and feedback through a post-event assessment. And in this post-event assessment, at the end of that, where the CE evaluation is linked, so if you stayed on to the whole event, you would have to click that in order to be able to get your CE credit. And the WebEx post-event, when the WebEx closes, the post-event assessment will pop up, but we'll also have Susan put it in the chat to make sure that you have the link. We want to thank you for that. We really appreciate your feedback, and you can also add any ideas for future calls there. So I want to again thank all of our speakers for today, Sue Fleck with CMS, Dr. Kate Curley and Ken Henriksen with the American Medical Association, and Joan Bardsley with MedStar Health Research Institute. And of course, thank you to all of our participants for being with us today. And Susan just posted that post-event assessment in the chat, so that's where you can get your CE credit at the end of that assessment. Thank you again to everybody for attending today. Have a great afternoon.
This concludes today's conference call. You may now disconnect.